Hello. Now we will start the Nishi Takahashi lecture by Paulo Kassab, my best friend in Brazil. So I will shortly introduce the background of Paulo Kassab. He was born in São Paulo in Brazil in 1958. In the March 16th. So he will soon get the birthday, yeah? And the foreign assistant spent 1 year in Paris as foreign assistant together with me. And he became a full professor at the general surgery department at the University of Santa Amaro in 1992 and ended up at 2008 and moved to the Santa Casa Medical School. And then in 2020, he became full professor of surgery at the Santa Casa Medical School. And now he is a coordinator of the Upper GI Surgical Oncology Department in the BP Paulista Hospital. And he contributed very much to this society, and also one of the very important member of Brazilian Gastric Cancer Association. So now we invite Professor Kassab. Please start your lecture.
Good afternoon, ladies and gentlemen. It's an honor, a real honor to be invited to this speech. I want to thank Professor Paul Monsfeld, Professor Brian Badwell for this invitation that honors me very much, and congratulate them for organizing such a wonderful Congress in so difficult times. Congratulations, Paul and Brian. I belong to the Department of Surgery of Santa Casa Medical School, who is a Mercy Hospital founded in 1562. It's a Mercy Hospital with seeing only public patients and sees the whole population. I also work in the private sector in the BP Hospital. It's a huge Portuguese hospital in São Paulo, together with my fellow Professor Bruno Zilberstein and other colleagues. But mostly, in my associative life, I belong to this very society, which I am very linked to since the first Congress in Kyoto in 1995. I also belong to the Brazilian Gastric Cancer Association with Professor Gama Rodrigues, who was the first president, followed by Professor Zilberstein as well. And it's the association that's the daughter of IGCA in Brazil, and we intend to continue to work in this association. For the younger who doesn't know why the name Nishi Takahashi, the name comes from Professor Mitsumasa Nishi, a surgeon, who was the president of the first International Gastric Cancer Congress held in Kyoto in 1995. I have a very vivid memory of Professor Nishi with Professor Ziever drinking beer in Munich in the second IGCC in 1997. And unfortunately, shortly after, he passed away. And Professor Takahashi at the time was his Secretary General. I have a problem here because I have a giant as my chairman. And it's very embarrassing because Professor Mitsuru Sasako is one of the pillars of the gastric cancer surgery in the world. And I assure you that when Professor Paul Mansfield told you the story about my friendship with Professor Sasako, he didn't know that I was a friend of Mitsuru since 40 years ago. And it's a coincidence. And here you can see Professor Sasako with my parents in my parents' home in 1990. And I tell always, if I use Sir Isaac Newton's words, if I've seen farther, it's because I was standing on the shoulders of giants. And I was standing in the shoulders of Professor Sasako, Professor Serna, who helped me to get to this day. Also, you can see him and my wife here, and my sons, who are old already, in the 1990s in the beach. Okay, so my theme is gastric cancer across the socioeconomic spectrum. I expect not to deceive you or to shock you, because you have seen until this moment very advanced speeches, and then maybe you'll be a little bit deceived because the reality around the world is not so good. So the gastric cancer care depends on the education and culture, depends on the home, the place where the patient lives regarding the center, well, where he will be treated. The nutritional aspects since childhood and the actual nutritional aspects, the access to medical services, also the financial conditions, the poverty, the sanitation, basic sanitation, and also the family support to undergo surgery. As Professor Zilberstein has showed already, 5.6% of the gastric cancers, of the cancers in the world are from in the stomach, and the mortality is much higher, 7.7%. Eastern Asia and West and South America are the areas of high incidence. And in this very interesting paper published by GBD study group in 200 countries, they found the same as the YARC found. High incidence in Asia, high incidence in West and South America. But when we look at the 15 countries, the highest incidence, only 2, South Korea and Japan, and maybe big cities of China, are developed countries. The rest are all developing countries or poor countries, such as Bhutan, Kyrgyzstan, and so on. We begin here to have a notion of what's happening. The number of deaths, it's 8,065 deaths per year, and the 19 million disability-adjusted life years around the world. In Brazil, the National Cancer Institute, represented here by Dr. André Maciel, who is here, shows us that among men is the 4th in incidence and the 4th in mortality, and the 6th in incidence and mortality among women. And as you saw in Professor Bruno's speech, the Brazilian population is growing older. So we expect a growing incidence of gastric cancer in the incoming years in our country. The first problem regarding the socio-economic aspects is that there are no screening programs. We do not have screening programs. This is a real problem, and in low and middle income countries. There is no statistical data. Even our National Cancer Institute, he does estimations. Professor Wilson Costa, who is here, who is living in Houston nowadays, is trying to establish a national registry, but we don't have a real registry on gastric cancer. The ESCO researchers several years ago, 2 years ago, they try to wonder if it's time to begin to screen those, but it's very difficult because it's expensive. And they say that the overall incidence is lower in low and middle income countries, but the total cancer-related mortality is much higher in low and middle income countries, especially among younger people. And the results of those deaths among younger is a loss of years of productivity, especially problematic in those countries. And in 2015, 80%, almost 80% of all global deaths attributable to non-communicable diseases, including cancer, occurred in low and middle income countries. And nearly 50% of the deaths were considered to be premature. If you see the disability-adjusted life years, you compare for Latin America, Brazil, Argentina, Uruguay, Chile, with Europe or the United States, the difference of years lost by premature deaths is immense. The difference is immense. The second problem is the access to centers for treatment. There are no health coverage system. In some middle and high income countries, this is true as well. This paper, the very nice American paper, the Global Surgery 2030, the evidence and solutions for achieving health, welfare, and economic development, show that the neoplasms are the second cause of surgery around the world. And when they project the gross domestic product loss for 2030, the neoplasms will surpass the musculoskeletal disease that were the first in 2010. This is a real problem because the cost is growing and growing and growing. To treat neoplasms is very expensive. Around 5 billion people, the majority of the world's population, do not have access to safe surgery and anesthesia. This is impressive. It's awful. If we consider those who could benefit from surgery to resect the cancer, these numbers must be higher. And in addition, each year, more than 30 million people around the year face financial ruin for payments for surgery or anesthesia. This very interesting and impressive map, the poorest billion, this was a study financed by Bill Gates Foundation. As you can see here, only Latin America, Africa, Eastern Asia, here are the poorest billion. This is impressive because 98% of those people use steel biomass fuels. 90% live in rural areas. Only 14% have access to electricity, and 60% do not have access to sanitation or clean water. This map, my fellows, this map is exactly the same as this one of the population without access to safe surgery and anesthesia. This is impressive. And when we put here, over this map, the map of gastric incidence is the same. What we are saying, that where we need most, we have less. This is a real problem we have to face. The estimated minimal total and unmet need for surgery by global burden of disease in Central Sub-Saharan Africa, 4,000 per 100,000 population. East Asia, 2,000. Eastern Sub-Saharan Africa, almost 5,000. The third problem is the distance to centers with a minimal condition to treat and diagnose gastric cancer. This is especially noted in big surface countries, such as Brazil, China, Argentina, India, Mongolia, and so on. There's a lack of adequate transport from remote areas to the medical centers. And the great majority of people don't have the means to pay for the treatment. We see this every day in our service. In this study, the distance to centers with a minimal condition to diagnose and treat cancer in high-income countries is 5 kilometers. In low and middle-income countries is 50 kilometers. But if I show you the next slide, the study we presented some years ago in the IGCC, in our hospital in Santa Casa, 62% of the people come from the north and the northeast. This is not 50 kilometers. This is 3,000, 2,000, 1,000 kilometers to come to our service. And I am sure that Professor Kodama, Professor Zilberstein, they have the same problem in their service. The Brazilian population is 200 million people. The access to private is only 40 million. And nowadays, with the pandemics, probably this is 30 million, approximately. We have the SUS, the free global service coverage for the entire population, but the SUS is frequently operating at the limit and receiving payment far below the needed. We are not well paid. If you see our map here, in each region there's a problem. The whole Europe fits inside Brazil. The North region is 45% of our territory, and with 18 million people living there. And the access to medical service is very bad. In this newspaper, we saw a lady telling that there's a 3-year waiting line to perform an endoscopy. So, because only a few centers in that region have conditions to perform a simple endoscopy. In the Northeast, you are used to see the wonderful beaches, but if you go to the countryside, it's very, very poor, with no access to surgery, to diagnosing gastric cancer. Those people, that's why they come to São Paulo, to Rio de Janeiro, and so on. In the central area, where there's a Pantanal, the marshy areas, big surface, to almost 20% of our territory, also few centers capable to treat gastric cancer. And in all those centers I showed you, here in the north, in the high incidence of gastric cancer, in the Northeast, high incidence of gastric cancer, center, as the same thing. And in the Southeast, we are richest region. But everybody comes, we are 90 million people. And we have to treat also people coming from other regions. The internal migration is really a problem in our services. We are burdened by people seeking for treatment in our services. This is not seen in the south because it's far away from the other regions. We have also this problem in some smaller countries dealing with political or extreme poverty, such as Haiti, North Korea, and some nations in Middle East, Central America, and Africa, and so on. The accessibility to centers after the diagnosis is also a problem. In our service, we receive frequently patients diagnosed more than 2 years before, because sometimes they had no comprehension of the disease. They don't know what they have. They have an endoscopy in their hands, and they come, and they don't really know what they have. They do not understand the disease. And also, if they comprehend, they do not have the access to referral centers. There's a delay of months or years to be operated on or to receive chemotherapy. First, due to the time to arrive to the centers. Second, because of what I told you some minutes ago, absolutely crowded referral centers with a long waiting line for treatment. This is my outpatient clinic on Wednesdays. Each Wednesday in Santa Casa, I see around 100 patients. And this is, even in pandemics, it's crowded. So many people waiting, people standing on the stairs. And I was very impressed 2 weeks ago when I looked in the terrace of my bureau in my outpatient clinic, and I saw this lady accompanying a person who was treating, sleeping on the ground, because they arrived at 3 a.m. in our service to treat. And the patients, when they arrive like that, in the final phases of the disease, very advanced disease. In our service, we around 1,500 patients, around 1,400 were adenocarcinomas. And as you can see, this is a tragedy, because 60% stages 3B, 3C, and 4, with the results you all know. The patients also in low and in middle income countries are operated on in service with more elevated morbidity and mortality, without the condition to continue the treatment or to understand the necessity of neoadjuvant or adjuvant chemotherapy. Even the physicians, the doctors, sometimes you tell them the patient has to do chemotherapy, and they say, no, I don't do chemotherapy, I will operate on the patient. Because they don't understand, they don't have the access to the information, unfortunately. This very interesting paper by TBD Collaborate Group, American group, studied the post-operative mortality and complications after gastric cancer surgery in 82 countries. And this is very interesting because in high-income countries, the mortality is 3.8% with 14.8% morbidity. In the middle-income countries, it is almost the same, 3.9% mortality with 9.2 morbidity, major complications. But in lower income countries, the mortality is the triple, 10.1%, with the major complications of 18%. Fortunately, in our service, we have 14% mortality, the same numbers that Dr. Kodama and Bruno showed some minutes ago, and 5.1 mortality. This is probably because we have trained personnel, but this is not the reality in Brazil. This ASO study, trying to improve the surveillance among in African patients. This is very interesting. They randomized 600 hospitals, and after excluding, they have 172 in one leg, 160 in another leg. What they tried to admit the patient to a higher care than had been planned before surgery, to increase the frequency of a post-operating nursing observation, to assign the patient to a bed visible from the nursing station, to allow the family members to stay with the patient in the ward, or placing the post-operative surveillance bedside guide in a visible position. And the results are surprising, because when they analyzed in-hospital mortality and in-hospital severe complication, there was no difference. There was no difference, even if they tried to do this. And the answer, we have to give this answer. The IGCA has to create a group to study that, because we have to look at the lower part, not only at the high advanced disease, but we have to look at that and to try to bring answers to that. Also, this very interesting paper from Colombian researchers together with our colleagues from Netherlands, they studied the gastric cancer survival and affiliation to health insurers in a middle-income setting. And what they found is when the patient is from a low-income setting, the mortality, the 5-year mortality is much higher, 31 versus 15% mortality. So this shows that the access to medical insurance is fundamental for those patients. Our survival in almost 1,000 patients is around 50%, and the stage-related survival is similar to those you have in your services. Another problem is after the surgery, the impossibility of the patients to receive the treatment. There are no infusion pumps paid by the government. There's a frequent lack of oncological drugs. So the oncologist, he had to choose which drug I have at that day. This is the reality. The patient's hygienic and cultural incapacity to deal with the pumps or the ports, they just don't know how to clean and to keep it clean and so on. And also, no financial means to pay for the transportation, even if the patient lives 100 kilometers from the center. This is true. If you look at this map, it's impressive. This is where patients have access to chemotherapy. All the gray area is where there are no rooms, no chemotherapy rooms in public service. 61% does not have chemotherapy of the regions, the health regions. They don't have access to chemotherapy. This is impressive. Also, if we talk about radiotherapy, all the gray regions, they don't have access to radiotherapy. 75% of the regions do not have access to radiotherapy equipment. Finally, post-operative or among the non-operative patients, there are no palliation and backup hospitals, no medical facilities of hospitals, hospice facilities or nursing homes, not enough beds for regular hospitalizations or in handicapped and final stage patients. So many patients die at home. And there's a lack of reliable data on diagnosis. The reality is the information about the cause of death is lost if you do not follow the patient personally. And in this paper, this is in Africa, all you see in gray and in white are patients who died without having the diagnosis, the real diagnosis. Finally, I want to finish this presentation with this wonderful painting I saw some months ago, a Van Gogh, The Prisoner Round. And immediately, when I saw this painting, I remembered my outpatient clinics. And when I saw this, I concluded that the prison to treat gastric cancer in many countries is socioeconomic. And the patients stay in this never-ending waiting line that frequently leads to suffering and death. And before I finish this presentation, I want to ask my chairman to show more 30 seconds of the slides. Today is the International Women's Day, so I want to honor our members of our council, Professor Heike Grabs, Fatima Carneiro, Vivian Strong, and Yelena Jandigia, and also the president of Brazilian Gastric Cancer Association and the scientific director, all women and a variety of specialties, only one surgeon, 2 pathologists and 3 clinical oncologists, showing that we are moving to this direction. And also to honor my family, Flavia, who is here, Carolina, my daughter, and my granddaughter, Daniela. And before finishing, I have to honor a person whose birthday is today, Professor Keiichi Maruyama. Today is his birthday. He's one of the founders of IGCA, and on behalf of whom I pay a tribute to all colleagues here and abroad who helped him to build this wonderful association. Thank you very much.
Thank you very much. So, due to the character of this conference, so I don't accept any question. But your talk was very impressive, and we have to think about the socioeconomical situation for this disease. Thank you very much, Paulo.